Thank you, Emmanuel. All right, so we're up to the debate section. So I'm not going to tolerate the no question sort of trend that's been happening. So I'm giving you guys some notice now. Start thinking up some questions as the presentations go on. Because the point of this debate is actually to get some audience participation and really get you guys involved in some of the discussion that's going on. So I guess I'd like to invite up the debatees. So we've got Professor Dr. David Wong from Toronto and Andrea Cox, who you guys have seen earlier. So I'll give you guys a little bit about the format of the debate. We're going to go a little unconventional. So the debate has actually been rigged in Andrea's favor because she already had 30 whole minutes to make part of her case this morning. So what we're going to do is we're going to give David 10. Okay, sorry. So the debate topic is, do we need an HCV vaccine? And so David is on the negative side, that we don't need an HCV vaccine, and Andrea's been given the pro side, so that we do need a vaccine. So the format will be, because of this sort of rigging of the debate. David's going to get 10 minutes to sort of make his case as to why we don't need a vaccine. And then Andrea's going to be given 5 minutes to kind of sum up her main points of why we do need a vaccine. And then I'll have a couple questions for each of them and sort of go back and forth discussing some of the issues around why we do or do not need a vaccine. And then hopefully, if you guys can think up some questions, we can get some insightful input to the discussion from you guys, the audience. So if everybody's okay with that, I'll hand it over to David to start things off.
All right, thank you very much. I only have a few slides, and I'm going to actually start off with, I think, what was missing from a lot of the talks this morning. It's the disclosure slide. And specifically, I do not consult for any companies. I do not participate in ad boards for companies. I do participate in a few studies. Now, when I looked at the program and I saw who I was going to debate, I of course had to Google her. And I note that she is an accomplished actress. She's been in a few shows that you may know of. And there's a little bit of a video if you want to click on it. So you know a lot about her, and she blinded you with science earlier today. You're already convinced. But what you need to know about me is I'm a loose cannon. And I don't know why you guys invited me. You should expect trouble.
Blame it on Jordan.
Jordan. So you should also know that I'm a Taurus. We break things. So I will offend. That's the other thing on my disclosure. I'm sorry in advance. Okay, so hepatitis C vaccine is clearly the pot of gold at the end of the rainbow. Do we need one? Yes, we do. I concede you win. But it's pie in the sky. Come on. Call a spade a spade. You heard all the difficulties with the science. It's not going to work. They tried with HIV. It doesn't work. They've gone to other strategies. You've got a study that's blinded, which is convenient because it's a code word for you're going to hear it doesn't work. Okay, so I think the debate is rigged in my favor because I actually listened to the sessions from today. So let me summarize some of the highlights. The things that were brought up about why the drugs may not be all as good as they are is because there's no immunity. Reinfection can happen after treatment. You have to ask yourself, if you're not immune after an infection, which is like all the viral proteins inside you already, how likely is the vaccine going to work? The drugs are too expensive, and resource-limited countries like Canada cannot afford these treatments. We are resource-limited. What about marginalized people? Right? I must admit, I have a few people that say, don't worry, I've got the cash. But most of my patients can't afford these treatments. We heard about resistance. Resistance is futile. We heard about transmission of PI-resistant RAVs. But seriously, who uses telaprevir anymore? Right? When was the last time anyone prescribed telaprevir? Can we afford longer treatment with the new agents? And it's also been brought out by the economists that the people who clearly benefit are the people with disease, not treatment as prevention. That comes later. But you have people who are actually at risk for liver failure, liver cancer. They have fibrosis. We need to treat them first. And the biggest bang for your buck right now is to treat those people who are clearly at risk. So I want to do a survey, and we're going to do another hands up thing. Hands up if you ever written a prescription for a Hep C treatment. Is that 10% or less of this room? Isn't that amazing? How many of you have cured at least 10% of your cirrhotic patients? At least 50% of your cirrhotic patients? At least 90% of your cirrhotic patients. How come? Where is the outrage? You heard today, I'm serious now, 2 talks about the experience in the real world, where in Calgary, all of Calgary, only 200 people got Harvoni or Hokura. That is it. In Montreal, it's only 80. Where is the outrage? Why is the treatment rates so low? You've got great drugs. Okay? What are the challenges in the real world? Clearly, it's the patients who need treatment are not getting access to treatment, and that's especially true for people with liver fibrosis. Morris pointed out that this meeting has been ignoring the biggest population in our center in Toronto, which is the immigrants, and they are the ones who are older with fibrosis and cirrhosis who are going to decompensate. And the main problem with access is cost of drug. After that, very shortly after that, is a lack of treatment capacity. There are not enough of us in this room who are treating. It's only 10%. It should be 90% plus. Okay? We are not engaging family practice. Why not? They should be treating, not specialists. Personally, you should also know this. I've announced it far and wide that I plan to exit from the Hep C field. I will be redundant in 2 years. My patients will be done. And that should be a goal that all of us in this room should set. We should hand over to family practice. So the other thing I want to point out is that there are a lot of distractions. So our goal clearly should be to be treating people with fibrosis. So what's distracting us? Well, we're treating people without fibrosis. If you have a capacity issue and you can only treat so many people, for every person that you treat without fibrosis to prevent transmission, you will be not treating someone with cirrhosis who needs treatment. Resistance testing, really? Do we need to complicate this even more for a 3 or 4%? Are you going to say to a cirrhotic, look, you have this resistance testing, resistance, I'm not going to treat you because your SVR rate is 92% instead of 96%? We didn't do that for interferon when it was 20%. And what about vaccine development? Can we really afford to divert all this money that could go to research into delivering treatment to trying to develop a vaccine which may never arrive? So I need to address the other thing that's not been talked about this whole day, the elephant in the room. The drugs are too expensive. Where is the outrage? Okay, so let's take a page from HIV. HIV is given up, not completely, but a lot on vaccination. We have PrEP daily, and we have PEP. For those of you who don't know, Gilead owns the market. It's just Truvada. Once a day, greatly reduces the risk of HIV transmission for those who are sexually promiscuous. And look at the other big picture there. There's advocacy. PrEP now, PrEP for all. Where is Hep C now, Hep C for all? We don't see that. We need advocacy. So if we're going to do a vaccine and it's a pie in the sky, this is my pie in the sky. My prescription would say PrEP H, PrEP Harvoni, PrEP hepatitis, or PrEP Zapardi, A, okay? And it would all be for $2 a pill. It would not cost any more than that, and they would still make a profit. I would give you a prescription for poverty, for housing, for food security. I would give you a magic prescription to get rid of your addictions, and I would give you a prescription to prevent gunshot wounds and knife wounds that you can't prevent with your vaccines.
Okay, so let's see. I laid out my arguments at about 8:30 this morning, so I have, how many hours to go now and figure out how to rebut your arguments? Okay, so I think most people, if not all, were here this morning, so I'm not going to reiterate the points, but I will start the debate right away, I think, and refute a few things you say. I agree I've not mercifully for patients, and I give a lot of credit to people who survived the telaprevir era, it was a challenging drug to use. And I agree, we're not using it anymore, but the point that I was making is that from the very first time we started using directly acting antivirals, we started seeing resistance and we started seeing transmission of resistance. And resistance-associated variants are seen with all the drugs that we are all prescribing every day. And so I think that we saw it as soon as it started, we're continuing to see it. There's no reason to think that resistance isn't going to become much more common. Resistance mutations in HIV, we also have had a series of great HIV regimens. We now know that we can't just prescribe the same HIV regimen for every HIV-infected patient because there is transmission of resistance mutations. And I think we have every reason to expect that we'll see that. So I agree that there's not a big problem with resistance now. There also wasn't a big problem with the resistance in HIV. But in some places, we've seen transmission of resistant mutations in HIV in 16% of cases. So I think this will probably be significant as we expand out into populations with more limited ability to comply with correct dosing, but not dramatically, because a big difference with HIV and Hep C is that, of course, the Hep C drugs are a little more forgiving in that you don't have to take them multiple times a day for 2 of the 3 common regimens, and you also can, in some cases, probably even miss a dose and you're still okay. So I'm not saying it's exactly analogous, but the point I was making is resistance occurred right away and will continue. I think in terms of the pie in the sky, there are a lot of significant advances in science that have required time to make them happen. And I think when we think about, hepatitis C was discovered in 1989. There's been a lot more money and effort put behind studying the virus to make directly acting antivirals. If we looked at the amount of money spent to design directly acting antivirals compared to vaccines, that may well explain why we're much farther along the path to directly acting antivirals. So I agree that it will cost money, but I think the investment has yet to be made. There are no big drug companies right now that are pressing hard for development of hepatitis C vaccines. And that's in huge contrast to what we see in the directly acting antivirals. So I think to say it's money wasted, we'd have to actually start spending some money on it for it to be wasted. It is the US government that's actually paying for the vaccine trial I described this morning. We have yet to get a pharmaceutical company interested in funding this. And you talk about justice and things. The reason is that the market for a vaccine is not there in the countries that really need it. In other words, the companies know that they're not going to make their money back if they invest in this because it's not a Western thing. So I think if we're going to talk about justice and fairness and where we want to spend money, I think that we really have to be considering that as a component. And then I guess the last point I would make before I give you back the floor is, well, maybe I've already talked too long. Is that too long? Okay. Yeah, oh shoot, no, I can't remember what I was going to say, so I might have to let it go. Yeah, I'll let you speak again because I have to think about it.
All right, well, David, I'm going to pin you to the post a bit because I'm not sure you fully sort of answered the question. So look, Well, I conceded. So let's try and have sort of a bit of a discussion about this. Okay, look, so the goal is potentially HCV elimination. That's where we're kind of headed with whatever tools we use in our toolkit, be it a vaccine or therapy. So I'm just curious, so David, sort of this is to you. So, we've had effective treatments for a number of different infections, for example, STIs like chlamydia. And we still haven't been able to eliminate these infections with pretty sort of inexpensive medications. I guess, how will HCV be any different? And what do you propose, what will be the sort of strategy to kind of move forward for that?
Andrea gave me the answer.
Well, that's perfect.
It's not, oh, there it goes. Okay, so let me just start off by saying I disagree with your stated goal of that we're here for HCV eradication. I think that's false. Elimination. Or elimination. I think our goal should be elimination of the infection in those who first need it. We need to have a tiered approach. We can't just it's impossible to just say, snap your fingers and Hep C is gone. So you do have to prioritize. We're nowhere close. That was my point. That we're nowhere close to treating the people who actually need the treatment first.
Okay.
We have to do that first, and that should be very, very clear. A vaccine, I think, for the goal of eradication is very tough. There are very few infectious diseases that we've been able to get rid of. Smallpox being one of them, but how many years did that take? Right? And polio, are we rid of polio yet? Not yet. Sure, North America, but not Africa, not India. So what about Hep B? We have a vaccine for that. How many of you have seen acute Hep B infection? How many of you have seen acute Hep B infection despite vaccination that has gone on to chronic infection? Okay, so it will lead us there, and I agree. I think we need a vaccine. I would love a vaccine. The question is, where are our priorities? And so, that's why I conceded. Yeah, do we need a vaccine? Yes, we do.
No, so you actually brought up a really great point, which is something that I was going to sort of bring to Andrea now. Can
I respond to that?
Oh, sure, you can respond to that, of course.
So it actually reminds me of the 2 points that I wanted to make that I forgot. One is that you talk about bringing the price down on drugs, and that's the goal. And so you reminded me. I think probably the single best example is not chlamydia, but syphilis. We've had penicillin since the 1940s. A dose costs literally pennies. I mean, it costs nothing. And it takes, in most cases, a single shot. We're not going to get DAAs that cost pennies and work in a single dose. And we have not only not managed to eliminate or eradicate syphilis, but rates are rising in many places throughout the world. So I think the notion that if the drugs get cheap enough, that's all it will take is fundamentally flawed. And then the other point I wanted to raise is not related to this, but we have to come back to the issue of reinfection, which I meant to say at the podium. All right.
So great if you could treat it like syphilis. There is a single shot of an siRNA that can get rid of Hep C that's being developed. Wouldn't that be great? That's something else that we can work towards.
Yeah, no, absolutely. So you brought up a really interesting point that actually leads me into a question for Andrea. So, I think, so first of all, we can agree that there's very diverse populations internationally, in the sort of high income, low and middle income settings. People who inject drugs are a priority population, and sort of in Egypt, it's quite a different population. So, and if we look at, I'll just focus on people who inject drugs for one example, but it's been very difficult to get really high uptake of vaccine for hepatitis B among people who inject drugs. So I was just curious, sort of, if we had an available vaccine, I was just curious if you had any thoughts, Andrea. I'm sure you've thought about this quite a bit, but how would we actually go about implementing that globally, given that we've got different populations and different at-risk groups, gay and bisexual. So it's a very complex, it's quite different than, say, hepatitis B, where you can just give a birth dose and kind of go there. So I'd be really curious to hear what you think about that or what your thoughts are.
Yeah, so I think that it's true that we still see acute cases of hepatitis C, B, obviously C, despite the development of a vaccine that's actually a pretty good vaccine. There are some populations that aren't great responders to it, but for the most part, it's an excellent vaccine. But I think what we'll see certainly less and less of it in places where vaccination is uniform. And when you look in Taiwan, they've seen reduced liver cancer from Hep B vaccination. In the United States, we've had vaccination of infants against hepatitis B, and while we see acute Hep B, I can tell you it's not in our 5- and 6-year-olds. It's in our adult people who are sexually active who've not been vaccinated for the most part. So I do think that we have seen dramatic decreases in acute hepatitis B. It's true that delivery of vaccine is a problem in many parts of the world, and one that needs to be solved, because obviously vaccines don't ever work if you don't get it. And so I do think we need to implement strategies globally to initiate vaccination. I think that, as with hepatitis B and hepatitis A, which we started vaccinating very specialized populations in most places, and have now moved to universal infant vaccination, I think that's the answer, because in contrast to treatment as a way to interdict transmission of hepatitis C, which has to be given during the time at which people are at most risk of transmitting, routine childhood vaccination makes someone resistant in a period in their lives when they're not participating in particularly chaotic behavior that makes following medical recommendations difficult. So I think the time to get on this is really as a childhood vaccine and not when people are actively injecting to avoid having to make this change during a high-risk period. How we get vaccines distributed across the world, we need more Bill Gates, basically. Yeah. I mean, we need more people who are willing to put in the World Health Organization and other important organizations to make that happen. And I wish I could solve that problem, but it's a hard one.
Sorry, Andrea, another thing just to follow up. I'm just curious, where do you see the role in terms of potential marrying together of interferon-free therapy and potential vaccine strategies, particularly to prevent reinfection moving forward?
Yeah, I think that to answer your question about why will it work to vaccinate people when natural infection occurs and is followed by reinfection, that rarely results in persistent disease and natural infection, as I said. So, I mean, in multiple studies, there's another study I didn't cite today, but basically multiple studies have shown that people who are infected once and control the infection are much more likely to repeatedly control. But after treatment, there's no induction. I mean, these reinfection studies after treatment show that treatment does not restore some immune function that allows immunity. But in contrast, and that's why I think you really need childhood vaccination, because it's a much higher bar to take someone who's already had Hep C. It's been shown that it doesn't work when they're chronically infected. The same vaccine induces terrible immune responses in people with chronic infection. They're thinking about testing it in people who've been treated. I make no guarantees about the immune response. This vaccine induces robust responses in a lot of people. We don't know if it induces robust responses in people who've been treated or how durable it is, which again argues to me that, I mean, it'll be tested, and I think we want to prevent people from being reinfected if possible, but that's a much higher bar. Achieving immunity that prevents infection when it's already in place before the infection comes is a lower bar than getting immunity after someone's already had the virus and learned strategies to evade it. Or the virus has learned strategies to evade the immune response. So it's a high bar. I'd rather we start with the low bar and vaccinate everybody as infants and not go for reinfection, but reinfection after treatment is a clear problem.
And I'll just remind people, look, now we've got some of the discussion going. Feel free to sort of jump up to the microphone if you want to ask any questions or join in the discussion about stuff. I'll ask a couple more questions just to kind of, and then kind of go forward. So I have a question for Andrea. So again, sorry. So because I think it's interesting, and a lot of the trainees are going to hear about some of this stuff tomorrow in terms of how you would actually go about sort of implementing this. But I'm really interested to hear. So say the phase 2 trials for the vaccine studies go really well. What are the next steps in sort of trying to convince people to move forward with the phase 3 trials? That in this population, it's really, I'm just really curious to know what are the next steps, do you think?
So I wouldn't be surprised if you asked me all the hard questions today, because, coming from a country that's seriously considering the Donald for president, I deserve it, so. Okay. So I think that one of the sorry, I'm as horrified as you guys are. I think that one of the things that you can say that the vaccine trial we're currently running shows is that it is possible, although challenging, to do vaccine trials in this patient population. For those of you who work with this population of people, you know the challenges, but you also know that there's reward in the work, and there are a lot of things that can be done. So it is not impossible to run a clinical trial in people who inject drugs. The other thing I would hope, but we don't know, will come from the trial is some sense of what the correlates of protective immunity might be. So if a subset of patients seem protected, we can find what responses induced prior to exposure protect. That might allow us to actually do trials in healthy volunteers. If not, we'll need cohorts like other cohorts around the world with a lot of experience in following and helping drug users, people who inject drugs, so that we can get a better sense of how to do this. And then the last suggestion was actually made by Mike Houghton at a meeting I recently attended, in which we say, well, the drugs are so darn good, we'll just vaccinate people and then intentionally infect them with hepatitis C. So that's something you can...
Credit to Mike. All right, cool.
Maybe you weren't suggesting we do that, but more asking if we were at that point.
So that's great. So we will go to the microphone. So Jordan Feld.
Okay, well, on that note, to follow with that idea from Mike, how good does a vaccine have to be? So, that, I mean, what is your bar for success? Because is a vaccine that, I mean, especially since you're only trying to prevent chronic infection, but if you're talking about, especially if you're thinking about global childhood vaccination, the vaccine, you'd like it to be as good as something like hepatitis B, and I'm not sure, as optimistic as I am, I'm not sure that's realistic, at least not with the strategies yet.
I mean, there definitely are some challenges, as mentioned, to creating a hepatitis C vaccine. And I think the study we're doing currently is powered to show a 60% reduction in chronicity based on some data that would actually make a difference worldwide in terms of the prevalence of hepatitis C. Vaccines, like many other strategies, I mean, you'd also have to combine this with other preventative measures. And the effect will certainly not be overnight, but I think that we could benefit from some funding and understanding immunologic responses to Hep C and knowing what responses you have up front are protective. And again, even if the trials don't work, if we learn that, we can then craft vaccines to induce those responses in settings that are much easier, like in healthy volunteer trials. So I agree it's a high bar. I think that, we've decided that really in order to go forward with this, we'd like to see something close to a 60% reduction in chronic infection. It's a contrast from HIV where you can say, okay, if we lower the HIV RNA level, we've done something because of the direct correlation between virus and disease. Here, we really do need to keep people from being viremic or it hasn't benefited anybody.
Great. Anything you want to comment, David? No?
I think you're doing a good job picking on her.
Morris?
David, you're right. You do offend. And I'm glad you apologized in advance. Actually, you're both right. But we're talking about apples and oranges here. David is talking about treating infected patients already infected. Andrea is talking about developing a vaccine for people, not patients, who are not yet infected. Andrea's vaccine will do nothing for that 170 million people around the world who are currently infected. That's a different problem altogether. And in terms of taking that cohort and preventing them from spreading infection, obviously if a vaccine is effective, it'll do so. I think to expect a vaccine to prevent it in everybody is unrealistic, at least at this stage of development. But if you can reduce the transmission rate, obviously that's beneficial. But even if this current trial is successful, that's still some years down the road before that is commercially available. So are there things that can be done in the meanwhile? And yes, there are. And the example, in fact, comes from Egypt, where better needle hygiene will probably have a direct and immediate effect on transmission in these poor parts of the world that probably can't afford the medications, even at the reduced prices that have been made available.
That's a great point, Morris. Does anybody want to comment on that?
So, Morris, I did concede on my first slide. I said we need a vaccine. Yeah, you're quite. I think it's very important to bear that in mind. They are different populations. We do have an obligation to treat that population that we have not talked about, which is all those people with disease. In terms of a vaccine, but that part of the world, the needle hygiene is not just that. It's also how good is your blood pool. Because I can imagine that your vaccine might be good for injection drug users where you're getting a tiny inoculum, but how good would it be when you get a whole unit of blood with virus? I'm not so sure.
Yeah, I don't think anybody really knows the answer to that. It's not even clear that inoculum size matters in Hep C, in that those data, people sort of give the dogmatic view that more virus means more transmission, but that's actually not been very well shown. So I don't think we really could say that if it works in people who inject drugs, it wouldn't work in people who are transfused entire units full of Hep C. And I wouldn't advocate that we employ one strategy. This is a little bit artificial in that obviously we both agree that everything you can do to reduce acquisition and to more effectively treat patients is good. But I would say that that's really the beauty of hepatitis C compared to other things. We do have a chance to actually control this globally because we can prevent new infections and treat people who are infected. That's not true of many of the other diseases that we worry about. So I think it gives us an almost unique opportunity to really suppress this virus to nothing potentially.
Great, thanks so much. the microphone.
I have a two-part question. I've heard discussion about the use of aborted fetal tissue in vaccines moving forward. A, is that accurate? And B, if it is accurate, what are the moral and ethical implications for that?
Yeah, thanks for that great question. I think one of the things that is a challenge to vaccination that I did not raise this morning, because it's in no way unique to hepatitis C virus vaccination, is the anti-vaccine movement. And one of the things that I would advocate we attempt to do is help the media be less sensationalist and portray accurate pictures of what happens in vaccination. The issue surrounding aborted tissue comes not from all vaccines, but from a specific vaccine, and that's the rubella vaccine. Rubella strain of virus used in the vaccine was initially isolated from a fetus, an aborted fetus, because of severe malformations due to congenital rubella. And the person who developed the vaccine had multiple potential strains of virus in the lab, and unfortunately, because it just didn't occur to him, used the strain. The virus was initially isolated from aborted fetal tissue. There is no fetal tissue in any vaccine used anywhere in the world, but the viral strain used in the rubella vaccine was initially isolated from fetal tissue from an aborted baby with severe congenital malformations because of rubella. So there are stories like, there was a British girl who got a human papillomavirus vaccine, and basically her brain, herniated through her skull. Basically, she had problems that they then blamed on the vaccine, and the British papers, big papers, put that the hepatitis, the human papillomavirus vaccine, she got it that day and died that day. The autopsy showed she had a brain tumor. It had been there for a very long time, and they neither reported the correction or reported on the last page instead of the front page, but it was very clearly not due to the vaccine. When you vaccinate millions of people, a bad thing might happen around the time of vaccination. That doesn't make it true. And the last anti-vaccine point I'll make is the measles, mumps, and rubella vaccine was linked to autism. The paper, it was subsequently, the data were shown to be falsified. It was retracted. The physician who did the study had his license revoked. That's not widely known, but what's even more horrifying to me is that if you look at the paper, the data are terrible. I mean, if you're going to fake data, make it good. I mean, I don't know why anybody believed that the vaccine was a problem anyway based on the data. We're talking about a study that took place in a few kids, double digits, not triple, not thousands, double digits of kids. And when they went back and interviewed the families, they said that the problems their kid developed with autism happened around the time of vaccine. The questions were leading. Did this happen right around the time of MMR vaccination was the question. And the second thing was the family said, I said no, and he reported yes in the paper. So there are lots of misconceptions about vaccines, and I don't know what to do about correcting it.
That's really interesting. The next question, the next person at the microphone.
Yeah, I was thinking, bringing you back to more the original debate question. I've noticed sort of with hepatitis C that a lot of the interest in the research was originally motivated by the high burden, particularly in people with advanced disease in terms of mortality, hospitalization, morbidity. And the issue coming now is probably one, I'm not sure what I'm actually hearing on this is, okay, yes, let's move on to vaccine now. Now we have a treatment, but then I'm hearing a lot of the physicians here saying we're just not treating enough people. And so with the resources, they're always tight. Maybe we can get that debate going a bit, is arguing, well, how much should go to vaccine, how much should go to treating, I would guess at this time almost, or where is it you're sitting on the anti-vaccine side? Not so much. We need both, and I think you're both agreeing on that. And all the disagreement is how do we come in. This conference, as people are saying, is heavily weighted on, say, vaccine or other issues rather than how do we get treatment out to people. Is that the issue? And so that was sort of the question on there to help my understanding of where things are going.
I think ideally they should both happen in parallel. I think that we have forgotten to look at the treatment piece in terms of how to optimize it. We have just heard a talk about different tools that you can use that might help in the management. But I think we are at a stage now, instead of doing more research, we really need to ramp up, and we should be doing research on how to ramp up that treatment. I think that it's that treatments are so easy. It's doable. It's really the level of family physicians who should be doing it. It's the cost is the issue.
Yeah, I think that's true now, but unfortunately, it may not be true. If we have issues with resistance-associated variants becoming more common, it may be that we really have to do an assessment of what the most appropriate regimen is for patients. I hope we don't get there, but I feel like there was a phase when HIV therapy was really well done by providers and then not, and now we're going back again where we have more broadly acting agents where it's easier for primary care providers. So that's the one caveat there. I think that in the States, the money comes from different pots. So it's not a do we do vaccine research or do we implement treatment, because those sources of funds are quite distinct for us. And in many places in the world, they're research dollars and they're dissemination of therapy dollars, and they're not linked. So it's also a little artificial to set them up as a one versus the other debate.
Well, yeah. So that was one of my questions. If you were to take, we can argue about the estimates, but between 250 and 300,000 Canadians infected, and drug costs that they currently are would be about $12 billion to treat everyone. So how do you achieve that? And I guess one of the questions, maybe, I don't know if David, if you have any insights, is, and maybe it's not something to address now. I don't know, Mel, if you guys are going to be discussing that in the later session. Mel's nodding no. So if David, if you want to take a stab at that, what do we need in Canada to move forward so that we can treat more people, and what's needed?
I think what we need in healthcare is a change in how healthcare is delivered in the U.S., because it's clear that the U.S. is driving costs of drugs everywhere. They set the standard, and everyone tries to fit around it. So what was very encouraging to me initially was that Merck set the price of their drugs very low in the U.S., but they did not do that in Canada. So what I would love to see is Merck set a price that is a tiny fraction of Harvoni. 30%, 20%, and then what I would love to see is, say, match that, or else you can only use Harvoni if you can justify why you need Harvoni over this. And that's the only way we can get a lowering of drug prices.
Okay, I realize, look, we could go on forever discussing this. There's 2 minutes, and I certainly can't sort of deny the two people up there sort of the opportunity to ask a question or make a comment. So just quick questions and quick answers, please.
Okay, so we'll come back to that crazy idea that got thrown out around the vaccine part and how you test the vaccine. I don't think it's such a crazy idea. If you're going to get me a vaccine that I'm going to take, I'd like to see that it actually works and it works in humans. So I'm apparently volunteer number one. You're assuming I'm Hep C negative.
Well, N equals 3 because Mike said he'd do it too. And then he volunteered me. And you did not ask me, but he said we'll be the first.
And there's a precedent, right? So in malaria right now, they're doing that at the NIH. They're sticking people in there. They've got drugs to treat it. They've got a potential vaccine. And then all these students go in. They get paid $500 every time they get a challenge, and they stick them in with a bunch of mosquitoes in this little arm thing, and they all get bitten with malaria-ridden mosquitoes.
Yeah, it's a technique that's widely used in other pathogens.
And I think it's incredibly appropriate that we give Professor Michael Houghton sort of the last question on this, given his sort of.
Well, thanks to Lisa. It's pretty much what I wanted to say, that there are precedents for vaccinating humans and then challenging them with the live organism. Malaria is one example, but there are others. It's not so crazy. We saw this wonderful data this morning that we can cure virtually all patients. So if we choose the right genotype to infect the vaccinees with, and we maybe give them a few months after challenge before we decide to treat, it will save a lot of money, because to do an efficacy trial in IV drug users is, to get statistical power is $40 million, something like that. And if you can prove efficacy, all you have to do then to get the vaccine approved is to prove safety. You give it to 10,000 people, show that it's safe, and then you get approval. So I really do think it's something we should consider seriously, given the fantastic cure rates that we heard about this morning.
Yeah, okay. I just want to say one quick thing, which is that we have in our clinic right now a young woman who's a genotype 1B infected patient who just failed a course of 12 weeks of Harvoni. So when you say that everybody is treatable, it's a tiny, tiny percent or not, and you would have to decide if you would enroll a subject in a trial whom you might actually give chronic hepatitis C. It's a possibility. But it's not a crazy idea, and I think we should discuss it.
So, you know what, with that, I would just like to, if you would join me in thanking Andrea Cox and David Wong, and I really appreciate everybody coming to the mic. It's been a